surgery. How do we have to treat PVR? Really, it's a problem of timing. We know that PVR is a dynamic process, and the immature membranes, if are not removed, may grow after the surgery. From some studies, we know that the epiretinal proliferation will take 6 to 12 weeks to develop and stabilize. But we also know that the delay of the surgery reduces the potential visual acuity. And how to treat this PVR? We like to perform a scleral buckling to reduce the anterior-posterior traction, microcannulas and small gauge surgery to control the fluidic and working in a closed groove, shave mode at the vitreous base, epiretinal subretinal dissection with bimanual surgery, perfluorocarbon and trypan blue to obtain a good membrane identification and removal, retinotomy when intraretinal or subretinal residual traction is present, ILM macular dissection to prevent the post-op pucker, silicone oil tampon at in most of the cases, in some cases Densiron, and medical treatment. We know that trypan blue is a dye with a high affinity to tissues with a high rates of cellular proliferation, like the epiretinal membranes. And these membranes in PVR are often poorly visible because of their transparency. The better visibility of these membranes will allow more complete removal with an early surgery, higher rate of long-term success, and finally a better visual acuity. Perfluorocarbon in posterior PVR opens the funnel, exposing the areas of preretinal, subretinal membranes, giving us an easier dissection. And perfluorocarbon stabilizes the retina during the membrane peeling, acting as a second hand holding the retina. The combination will allow more complete removal, and usually we employ 2 minutes the trypan blue staining under fluid. And why the removal of the ILM in PVR? We have less risk of recurrence of macular epiretinal proliferation after ILM peeling, and Shimada and co-workers observed that the recurrence was 16% without the ILM peeling versus 0% with the ILM peeling. And scleral buckle will sometimes relieve the traction and avoid the retinotomy. But if there are a complete meticulous epiretinal and subretinal dissection, if retinal contraction remains, we'll perform a relaxing retinotomy. Peripheral retinotomies are less functional significant than posterior retinotomies, and circumferential relaxing retinotomies are preferred to radial retinotomies. But really, the results are not spectacular, between 70%, 83% of the cases. But if you see of the Colomeyer and co-workers publication, 37% of the cases had recurrent retinal detachment. Visual acuity, the final visual acuity in the Binay and co-workers publication was only in 200 or better in 40% of the patients. And in the Beckner and co-workers publication, they had more than half of the cases that required more surgeries if they performed the fair laser photocoagulation. This is a 22-year-old woman, myopic, with 2 previous surgeries, and the visual acuity was hand motions. And this is the approach of this lady. And we use the trypan blue staining. And after, we perform a perfluorocarbon reattachment of the posterior retina and a small retinotomy to drain this fluid that we have displaced peripherally. And we enlarge a little more the bubble of the perfluorocarbon, and the dissection of the membranes is quite easy because we can identify quite well all these peripheral tissue coming from the optic disc towards the periphery. And really, it was a very contracted PVR that covered almost all the posterior retina. And under perfluorocarbon is quite easier because the retina remains stable, remains attached, And this membrane was not visible before the surgery, and now we can dissect the membrane because it's stained with trypan blue. And really it was a big membrane coming up to the vitreous base, as you can see, and we removed through the trocars for histopathological analysis. Some of the membranes didn't stain so well, but we were able to remove with a bimanual technique, and after laser was placed at the limit of the previous laser, and silicone oil was introduced into the vitreous cavity. And this is the typical intercytoplasmatic melanin granules that have these membranes with a higher rate of cellular component. And this is the post-op appearance with 20/50 visual acuity. This is another patient with penetrating trauma to previous surgery, light perception, a closed funnel. And we performed, in this case, a temporary keratoprothesis, and both sides of the retina were separated because they were engaged completely, and we stained the membranes, and with a bimanual surgery, we remove as much as possible all of these membranes, giving us the possibility to go to the posterior pole and really to perform the dissection of the PVR that was over the optic disc, but also in the macular area. And now we are dissecting the ILM in the macular area to prevent the epiretinal proliferation in the post-op period. We have to remove as much as possible all the proliferative tissue, but in some cases, even after removing this tissue, this contracted vitreous base, and it's really difficult to reattach the retina. We perform a diathermy, and after, with the 23-gauge vitreous probe, we perform the retinotomy. It's really a very good technique with the vitreous probe. We can do with scissors, but probably it's better with the vitreous probe. And a perfluorocarbon was injected into the vitreous cavity. Some folds were unfolded, and at the end, the laser under perfluorocarbon was performed, and a direct silicone oil perfluorocarbon exchange was done. And this is the post-op appearance. And this is 1 week after the surgery and the final case. And this is another tough case with a very deconstructed anterior segment with a closed funnel. And we performed also the dissection of this membrane that was in the iris. And a keratoprothesis was employed. And this case really we stained as much as possible. But the main problem was not epiretinal, was more subretinal. We dissected as much as possible all the epiretinal proliferative tissue, but really the main problem were these strands that were in the subretinal space, and that didn't allow us to reattach the retina. We can see here this band that is really very dense, and we performed a retinotomy, and this is the very proteinaceous fluid in the subretinal fluid, and the 360 degrees retinotomy was performed, and these are the subretinal strands that were very attached to the external retina and didn't allow a good reattachment. It was a quite important quantity of subretinal membranes, and we could remove as much as possible all these strands that come probably from the cells of the RPE. And after the dissection of the subretinal space, we re-injected perfluorocarbon, and we placed it at the trocar. And this is after 1 week of the surgery, and this is after 1 month with 2200 visual acuity with little rotation of the retina. What about the anti-inflammatory agents? Also, they suppresses the expression of inflammatory markers, but does not decrease the severity of experimental PVR in this study. The systemic steroids, the triamcinolone, it was performed a meta-analysis of 3 controlled trials, and it was no statistical significant difference globally, but yes in PVR grade B or lower. The anti-neoplastic or anti-proliferative agents, like the 5-FU or low molecular weight heparin, did not decrease the PVR, but increased the hemorrhage. And at the end, the visual acuity was lower using these drugs. Danoromycin was ineffective when using as a single agent. And the antibodies against the RPE integrins, like the anti-EMP2, prevent the migration of the RPE cells from the vitreous cavity and may be helpful. The neuroprotection, the inhibition of the photoreceptor degeneration after retinal detachment is interesting, mainly with the anti-TNF-alpha that inhibits the proliferation, differentiation, and cell death. And genetic biomarkers will identify patients at high risk for developing PVR. And in conclusion, after 40 years, there is still no method to prevent PVR. We use the microcannula small gauge instruments and correct parameters to increase the safety. We have a more complete and safer removal of the PVR with the combination of perfluorocarbon and trypan blue staining, allowing early surgery. We have to remove the macular ILM in those cases to prevent the post-op pucker. Retinotomy is important if residual traction is present, and pharmacological therapy and genetic markers will improve the anatomic and final visual acuities results. Thank you very much.
Thank you very much indeed, Pepe. Do we have any questions?
Thanks. In these cases that you go for trypan blue, does it differ if the case is a phakic or a pseudophakic patient? Do you change any technique? Do you do a air fluid exchange and then you stain with the trypan blue? Because we have that concern that maybe the trypan blue will color the posterior capsule and alter our vision. This is the first question. The second question, on those cases that you have done a 360 retinectomy, what's the mean of silicone oil removal time after doing these surgeries?
Well, the first question, we use the trypan blue made by DORC that has polyethylene glycol, it weighs more than water. And really you inject and all the trypan glue goes towards the retina. If you perform a fluid air exchange, probably the stain will be a little better. But I prefer not to do a lot of these changes. And this made by DORC, I don't have any commercial interest, but goes to the posterior retina. If you want to stain a little more peripherally, you introduce the perfluorocarbon first, and you stain with the bubble of perfluorocarbon inside, and you can stain more peripherally. But I think it's enough. And the second question, really, if it's possible and the ocular pressure is okay, over 10 millimeters of mercury, I prefer to remove the silicone oil. Silicone oil, we know that we can leave into the eye a lot of time, but the visual acuity will be better if you remove the silicone oil. And some concerns of toxicity of long-standing silicone oil were very well presented yesterday, and really I think it's much better that to have the eye with aqueous humor than with silicone oil.
But what was the mean time that you removed the silicone oil?
Usually in 2 months. If I can remove the silicone oil, the ocular pressure is okay. In some cases, you have some epiretinal proliferation remaining, and at the time that you remove the silicone oil, you remove the epiretinal membranes because you don't have retinal detachment. You have only small areas of traction of the PVR. 2 months is the best.
Okay, I'm sorry, we have to move on. Thank you very much indeed, Pepe. So our next speaker is Morten Lacour, who's going to tell us about retinal detachment in Denmark. That's very nice. Your videos are always stunning.
Thank you, Bill, for giving me this opportunity. What I'm going to